Hi there. Thanks for joining us today. I treat a lot of hip pain in my practice and have this question come up on a daily basis. Do I need a hip replacement? Will a hip replacement help my hip pain? So I thought this would be informative to go through some of the main causes of hip pain and what the hip replacement does and doesn't do. And, hip pain can be mild, but can be really debilitating. And it's really considered a public health concern based on the time out of work and disability that it can cause. But there are a lot of potential causes, and that's what brings us to this point today. Is it's a really complex area. The hip has a lot of potential pain generators, and trying to figure out exactly which pain generator is bothering you is the key to treating you appropriately. And there may not be just one specific pain generator, and so ruling them out one at a time often is the way to go. And so it starts with getting just a good history of the pain. Is how did it start and how long has it been going on? If it was after an injury, then that may point us towards one direction, maybe more muscle tendon involvement versus it just started insidiously. And if it is aggravated by certain activities and alleviated by certain activities, then that helps direct us down that path too. The mechanical symptoms part is important. Popping is usually the joint itself, and there's a few joints in there that we'll talk about, but popping is an important symptom to pay attention to. And then any nerve-like symptoms usually are nerve-like problems. So numbness, tingling, weakness in a certain area kind of points us towards more of a nerve problem than the joint itself. And just like real estate, location matters as far as where the pain is. And pain in a certain area helps rule some pathologies out and some in. So normally the hip joint itself has a lot of groin pain, and most people with hip arthritis or a damaged hip joint have a lot of groin pain. Now that's not all the time, but that's the most common. Pain more towards the side or towards the buttock is usually something else. There's the bursa on the side, the tendons on the side, and then sacroiliac in the back of the hip. And we'll talk about those a little bit more. The exam portion is important as well, and the range of motion. If you start having limited range of motion, that's almost always the joint that's involved. And that's the most important part of the range of motion. Certainly tenderness over a certain structure, so that's where knowing exactly the anatomy of the hip matters. Is if you have tenderness to touch an area, usually that area is a pathologic area. So on the side of the hip, if you're really tender there, that's almost always the bursa or the tendon on the side of the hip. You may also have arthritis, but you just can't quite put your finger on the hip joint to have tenderness from just arthritis. Weakness and sensation changes, again, may be more of a nerve pathology. And then certain provocative maneuvers, so twisting the hip a certain way, that really irritates the hip joint the most. So range of motion pain often is the hip joint as well. And then walking can cause pain in lots of different areas, but that's important too, because no pain at all with walking can rule in or out some of these pathologies that we'll talk about next. The imaging is then the next important thing that we'll do to try to help rule this in or out. And the x-ray is the first easy thing to do in the office. And you can certainly get a lot of information about the joint itself. So on the left side of the screen, that hip joint is very arthritic and it's severe. That's what we would call end-stage arthritis of the hip compared to the right hip on the screen. Now, the severity of the x-ray finding doesn't always correlate with the pain. And so I see a lot of people with an x-ray just like this, and the really damaged arthritic hip may not cause them a lot of pain, and the other hip may be much more painful. So the x-rays don't always correlate to the pain, but that certainly leads us down the path of what to do next for a patient like this. The next imaging is the MRI. So if we say we don't get enough information from our x-ray, or if we're concerned about the soft tissue part of the hip, then the MRI is the next imaging. And it's highly detailed to see the tendons and the muscle structure around the hip. It also shows the cartilage much better than you can see on an x-ray. And that helps lead us towards these diagnoses. And we'll kind of go through each of these. These are the most common 6 or 7 things that we'll see on a daily basis that are causing the hip pain, and we'll help kind of rule them in or out here. So the hip joint arthritis, the arthritis of the hip joint means inflammation of the hip joint, but to an orthopedic surgeon, arthritis means damaged cartilage. And the findings say on this x-ray, there's about 5 things that we see that are indicative of arthritis, which are the joint space is narrowed. So almost no joint space means bone-to-bone arthritis. You get sclerosis of the bone, which just means it's really dense and thick because the cartilage has gone away. You can get cysts that form in the bone, and that's part of the progression of the arthritis. When cysts start to form, you start to get bone loss. So if the hip joint starts to become deformed, that's one of the most advanced stages of the arthritis. And that's when you get such limited range of motion of the hip. When it's no longer a ball and socket, then it doesn't twist or turn as well as it should. And you get a lot of stiffness from that. And then bone spurs. So those are the 5 things that this x-ray kind of points to on both of these hips, that this is an arthritic hip. Labral tearing is another diagnosis that we're seeing more and more of, which is the cartilage rim around the hip socket and not the weight-bearing cartilage itself of arthritis. It's the actual rim of cartilage around the hip, and that can be torn. And that usually is torn every time you have advanced arthritis, but this may be the pathology that leads a hip to more arthritis. The labrum usually comes first. And if you can catch it early enough, sometimes the labrum is fixable, and that may help prevent some of the arthritic changes. Then the bursa is just a fluid-filled sac that the body creates anywhere there's friction. And so the most common place that we see this is on the side of the hip. The greater trochanter of the hip has a large bursa, and that's the most common bursitis problem that people have. But there are several other bursas around anywhere there's a bony prominence and there's friction from hip motion. Then hip tendon pathology, so the tendonitis part of the hip. There are a lot of tendons around the hip, as you can see. And so the figuring out which tendon is involved that causes the tendonitis helps kind of direct the treatment. But the pathology usually comes from tendonitis, which is inflammation of the tendon. Partial tearing is kind of the next stage, and then complete tearing. And though that's really a spectrum of tendon pathology, the most common is the gluteus medius tendon, and that's the main hip abductor, the main tendon that fires as you're using the hip. And so that's the one that gets the most damaged. And we see that, say, on this MRI example. You really need an MRI to be able to diagnose that specifically, and we can see if it's a partial tear versus a total tear, and then what the treatment for that would be. The other most common pain generator we see is when the pain is more in that buttock region, or the low back central buttock region. That's the sacroiliac joint almost every time. And that joint is the lowest level of your spine, the sacrum, where it meets the ilium, which is the part of the pelvis. So all of your weight bearing goes through those joints, and they can be inflamed. You can get little fractures there if you have stress fracturing for various reasons. And then it can get malaligned. And every time you go from a seated to a standing position, that joint rotates just a little bit. And if it gets malaligned because it's arthritic or inflamed, that causes a severe pain, and it's usually in that location, and that's not the hip joint. Then fracturing of the hip. So fracturing can be on the femoral side of the hip joint or on the pelvic side. And almost all of these fractures are considered osteoporotic fractures, meaning they happen because the bone is soft. You shouldn't get those fractures from normal day-to-day things or from having a fall from a standing height. These bones are strong enough that they should not do that unless you have osteoporosis. The femoral-sided fractures on the left side of the screen are almost always treated surgically, whereas the pelvic fractures on the right side of the screen are essentially never treated surgically unless there's a high-energy trauma for that. And then the final source of hip pain can be the low back. And the low back source is when a nerve is pinched or irritated or impinged, and you actually have pain in the hip or the leg. And so that lowest level of your lumbar spine, those nerves go towards the hip and the lower leg. So pain along the hip in a certain distribution, along with usually some nerve symptoms, helps us point towards it's actually a nerve problem and not necessarily the hip problem. Now, determining which of those is the pain generator then directs some of the treatment. Now, most all of those are treated the same way initially. So even if we're not sure exactly which is the pain generator, typically the anti-inflammatories is the first treatment. And so if you can tolerate, say, a non-steroidal anti-inflammatory, that's the first treatment. If you can't, for various reasons, other medications or heart problems or stomach problems, then steroids is the other option. And there's topical, oral, and injection forms, and those all have their role, and we'll talk about that next. And then just modifying activity. So whatever is bothering it is, if you can avoid that and rest and avoid that certain activity long enough to let that area heal, then that's the other first treatment. And then physical therapy has a lot of modality treatments. And a lot of people think of physical therapy as just getting on a bike or strengthening, exercising, and that has a role. But for a lot of these pathologies, especially the tendonitis part and the bursitis part, the therapy has a lot of modality treatment. So ultrasounding, electrical stim, needling, and scraping. These are all modalities that actually help with that inflammatory phase of the pathology. Then surgery, and we'll talk about that. The surgery based on what the diagnosis is. So you got to have the diagnosis first. And one of the best ways to tell is with injections. So the injections has the diagnostic part, which helps prove whatever the pain generator is should get better if we put an injection in that area. So that's the most important thing I think I do is when you have some pain that's not perfectly classic for hip arthritis, growing pain, a terrible x-ray, then oftentimes an injection helps, even just with numbing medicine into the hip joint. And if you get pain relief, then the hip joint is the source of the pain, and surgery on the hip joint would be the best surgery option. There's also just the therapeutic effect of the shot. So the cortisone portion of a shot should give you relief, anti-inflammatory effect, and that may take care of the problem. And so getting some relief from the shot or no relief from the shot are both helpful in deciding where to go from there. And so when you need a hip replacement is when you have significant pain or dysfunction from the hip joint or the bone around the hip joint. And usually that's end stage hip arthritis that's failed other conservative measures. So if you've failed the anti-inflammatory rest injection side of things, and once you're medically optimized, and there's a lot of things we look at for that, but if you have diabetes and your blood sugar's controlled, if your weight is in an acceptable limit, and if your heart and lungs are functioning okay, then you're considered medically optimized as far as the most important things that we look at. And then if you have a fracture of the hip or an impending fracture, so either that osteoporotic fracture, or if there's a reason that you're having an impending fracture, like the bone is so osteoporotic, or if we see a tumor in the hip, something we think is going to fracture soon, those are reasons to go ahead and replace the hip as soon as possible. Now, if you're told and we've come to the conclusion that you need a hip replacement, that's maybe a good thing. It's better than, say, replacing the rest of you. The hip replacement works so well. That's our currently best surgery for hip joint problems. And it's been called the operation of the century, last century. It has some of the best reported outcomes for any of the surgeries that we do. People do so well when you have hip disease and we replace the hip, because it is a ball and socket hip joint, and so it can be replaced really easily. And now with recent advances in, say, the implant materials that we use, so the most of the bearing surface and the material we use should last for the rest of your life. There's very little material wearing out like it did in previous generations. The techniques to actually do the hip replacement are more minimally invasive. So the anterior minimally invasive muscle sparing techniques that I do help speed up that recovery. And so the rapid recovery of this has also allowed it to be an outpatient surgery. So most people now are able to have their hip replaced and go home the same day because there's just such minimal invasiveness to the surgery, and all of the protocols that we have in place just work so well for that. Now, the hip replacement again is, say, the ball and socket normally should be smooth and a perfect round ball and socket. When it becomes damaged, arthritic, irregular, that's the part that is replaced. And so that bone is removed and the cartilage is removed and the hip replacement is put in that same spot. So that is the ball and socket part of the hip replacement. And that's, again, that's why it works so well. If we can do that without damaging the surrounding muscles and tendons, then the recovery is just really, really fast. Now, even though it is a really, really great surgery, there's still the potential complications, and you have about a 1% risk of an infection, of a fracture, of the hip dislocating, and of the hip being a different length than the other hip, which is only if it needs to be lengthened to tighten up the hip joint, which helps prevent the dislocation part. So we'd rather that hip be just a little bit longer than the other hip, as long as it's stable and doesn't dislocate. And most people can have the exact same leg length and still have a stable hip, because the hip, again, is done so minimally invasively. There's very little instability, and that's about a 1% risk of those things happening. And then you can still have pain afterwards, and there's all those things we looked at that can cause pain. You may still have some pain. That's why it's so important to pinpoint the hip joint as the source of the pain. Now, other things that may hurt the tendons, the low back, the sacroiliac joint, all those things usually get better after the hip replacement because the hip is moving better. So that secondary kind of compensatory pain that you may have as a result of the main problem of the hip usually gets better too, but there may not. Some people still have some other pain around the hip. And then the implant itself failing or loosening, if the bone loosens around the implant, that is this real small potential complication. And so that kind of points us towards the hip replacement. When would it be beneficial is really when it's localized as the main pain generator. And so going through that systematic checklist helps us rule in and rule out that hip joint. And so that's just a brief overview. And I think this question portion often is the most helpful for any specific questions that anybody may have. Go ahead and feel free to ask. There's more information at these websites, the Hip Replacement Knoxville and the Talk Docs website for any other information you may want.
Thank you, Dr. Dabbs. You hit on some points I was going to point out, so thank you very much. While we wait on some questions to come in the chat box, does everyone see the chat function at the bottom? If you kind of move your mouse over your screen, your chat will come up at the bottom. But just while we're waiting on a few of those to come in, I just want to thank everyone again for taking the time out of their day to join us on this presentation. We hope you enjoyed. There's a couple ways that you can schedule with Dr. Dabbs if you're interested. As he said, you can go to talkdocs.com and there's an online scheduling tool there. You can call us at 865-690-4861. And I will type this in the chat box. That way you guys have it as well. There's one other way.